Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody's doing great. Welcome to the second day of the crash course. Today, we are going to talk about a few other most commonly tested topics. We're going to start with the first one, which is very, very commonly tested, neurocognitive disorder. Let me put it in slideshow. Okay, now it's much better, right? All right. Okay, the learning map. Today, from this lecture, we should be able to know how to classify when it comes to neurocognitive disorder, whether it is mild or mild neurocognitive disorder, or it's a major neurocognitive disorder, or it is something like delirium, which is acute confusion. Then recognize Alzheimer itself, which is very commonly tested, very commonly tested, and the key dementia mimics. And there are certain other conditions that they are mimicking dementia, but they're not actually dementia. We call it pseudo dementia. Or there are some genetic dementia that we need to discuss. So we should be able to classify whether it is mild, major, acute, whether it is Alzheimer, it is genetic dementia, or it is another condition that is mimicking dementia. Then we should be able to order investigation accordingly and also manage accordingly based on what we're dealing, whether it is mild, whether it is normal to the age, whether it is major neurocognitive disorder, whether it is acute, Alzheimer, the genetic one, and also how to go about the condition that they are mimicking neurocognitive disorder. And also apply pattern recognition for MCCQ1 clinical vignettes. So we're going to have some clinical vignettes that shows how these questions are going to appear. MCQ rule, function determines mild versus major neurocognitive disorder. So it means if the functionality or the day-to-day activity is affected or lost, it is major. If it is still intact, then it's mild. Okay, we're going to talk more about it. Acute fluctuation with the intention, attention is delirium. If there's a fluctuation and the patient does not have attention, in that case, it is delirium or acute confusion. All right, so now let's talk about the neurocognitive disorder that happens in different stages. One is called normal aging. As we age, like everything else that is declining, the memory is declining as well. So it is a normal progress in our life or a normal decline in functionality of the brain that we sometime or occasionally we misplace some stuff. We don't know where we left the key or something, which is normal based on age, right? Usually after 60, people tend to develop a little bit of the memory problem, which is normal based on their age. Now, the second stage is the mild neurocognitive disorder, which is objective decline. It's not like a normal one, it is objective decline. And activity, daily activity, and instrumental activity during daily life are still intact. You more often, comparing to the normal age, you tend to forget things, but still you can do day-to-day activity. You can still function properly. So it is mild. But if it affects your daily life, then it is major. It moves on to the red, not red zone, but it's like a gray zone between. We can also call it like a mildly on the red zone area because you're losing the functionality of daily life. So it is severe form of the neurocognitive disorder. So now you're losing the functionality of daily day-to-day activity. For example, you cannot cook, you cannot drive, you cannot do other stuff that you normally do on daily basis. Then we have delirium. Delirium is an acute confusion state of mind that it is fluctuating. The patient not only have dementia, which is acutely happening, the patient may also develop psychosis, hallucination, this and that we need to uh, differentiate. Now, diagnose mild neurocognitive disorder is cognitive decline, but independence is preserved. It means you can still live by yourself because you can still function as a person. You can do your day-to-day activity. So you can still be independent person. Major neurocognitive disorder is loss of independency. Now you're dependent on others to help you on your day-to-day activity because not only you have memory issue, you cannot function properly. So you don't know how to drive, or you don't know how to go to the market and come back, or to go back to the, for example, store and come back. So you lose all those ability. You become a dependent to somebody else to do that with you or for you. And delirium is acute fluctuating course with inattention. Normal aging, no progressive functional loss, usually 60 or above 65 would be the cutoff. IED is instrumental activity of daily life. ADLS is the activity of daily living. Now, mild neurocognitive disorder, the definition is measurable decline in one or more cognitive domains, but the patient remains mostly independent in daily life activity. So the common clues, the patient will be forgetfulness, word finding difficulty, slower thinking, reduced concentration, mild executive or spatial problem. These are the clue. But the most important thing to remember in order to be able to differentiate it from a major neurocognitive disorder is, can the patient do the day-to-day activity? If yes, this is mild. Okay? If the patient cannot do it, then it's major. Just to make it very simple. Now, it has some subtypes. Subtype is called amnestic, non-amnestic, single domain, and multiple domain. When it is mild neurocognitive disorder, but amnestic type, it means it is more amnesia predominant or memory predominant, most associated with the Alzheimer pathology. If the patient has mild neurocognitive disorder, but it's non-amnestic. Non-amnestic, it means the memory is not predominant. The patient have problem with the language, cannot find the proper word. Like he's looking for a proper word to use, or he's missing out on words. He has problem with attention. He cannot focus, or executive or visual spatial domain affected. So single domain, either this part or this part. Once cognitive domain affect one cognitive domain is affected, either the amnestic or non-amnestic. Multiple, both of them. Mild neurocognitive disorder is a risk state, not guaranteed dementia. Follow cognition and function over time. Now, this one should explain it a little bit more in details. What do we mean by the amnestic cognitive disorder? So, memory predominant, cognitive decline, think of Alzheimer. If the patient has mild neurocognitive disorder, but it is memory predominant, like the patient has problem with the memory, he cannot remember things, but the language is okay, the execution is okay, the functionality is okay. So think about Alzheimer pathology. Non-amnestic, main problem is not the memory. It is something else like language, attention, this and that. For example, he remember the faces. Okay. Single domain, only one cognitive domain affected. Example, memory only. The patient has only memory problem. Or multiple, the patient not only have memory problem, the patient has, for example, language problem too. Not only the memory, he cannot remember the numbers as well. He cannot recognize objects as well. He cannot remember the faces as well. Okay, so the classification, how to quickly classify it? How should we know that this patient with a mild neurocognitive disorder has which subtype? So to make it easy, ask this question. Is memory the main problem for this patient? If you say yes, so it is amnestic subtype. If you say no, then it is not amnestic disorder subtype. How many domains are affected? Is it only the memory or it is the language, the attention, and also he cannot recognize faces and object? Then in that case, it will be multiple. Now, major neurocognitive disorder. So functional is lost. Functionality is lost. Not only the patient has issue with memory, but the patient cannot function properly on doing stuff which is required for an independent person to do on daily basis. Major neurocognitive disorder acquire cognitive decline that interferes with the independence. He cannot be independent. He will be dependent on somebody. Cannot manage finance. So that's the most important part of the life, right? Medication error. He cannot take his medication because he cannot remember it, right? Leaves stoves on. He cannot cook. Get lost in a familiar place. Like you know how to get to the supermarket and come back to your own home. That's something you cannot miss out on or screw up, right? If you lose yourself in the familiar area that you on daily basis, you're going to the market, you're going to the supermarket, you're going to the gym, you're going to, for example, park, come back. So this place is very familiar. You shouldn't be lost here. But if you lose yourself here or you get lost in a familiar place, then it is a major neurocognitive disorder. Unsafe driving. If you don't know how to drive, needs help with shopping or cooking. Wandering or false requires caregiving supervision. So now you lost the functionality as an independent person. This is called major neurocognitive disorder. The cognitive scores matters, but function decides mild versus major. So the most important part that you need to know when it comes to mild and major, does the patient still function independently or he is a dependent? If the patient is independent, he can do everything, it is mild. If the patient is dependent on other people to do stuff for him, this is major. Now, do not diagnose dementia during delirium, obviously. So in delirium, the patient will be confused, so he cannot remember anything, but doesn't mean that this is dementia. It could be delirium. So during delirium, you don't diagnose dementia. So the feature are onset, course, attention, consciousness, urgency. Delirium is very acute, but major neurocognitive disorder is gradual. It will take months to years to develop. But for delirium, it just takes hours, right? It's very acute. Now, the course, fluctuating, the patient is getting better and worse, better and worse. So, like on a matter of minutes and hours, the patient is getting better and worse, better and worse. It's fluctuating. But in major neurocognitive disorder, it is progressive and is slowly progressing, or gradually it's progressing. It's not getting better, it's only getting worse. Attention, the attention is impaired, often preserved early in major. Consciousness altered, fluctuating. The patient is getting better and getting worse in terms of consciousness, and also usually normal. The consciousness for the patient is normal because it's not something very acute. Urgency, it's a medical emergency. The patient has to be in the hospital and should receive medical attention. It is chronic evaluation. We have to keep doing follow-up for the patient. So for the delirium, acute fluctuating course plus inattention, disorganized thinking, or altered consciousness. Confusion assessment method, acute fluctuating attention. So first check for somebody that you think might have delirium. First check ABC, vitals, oxygen, capillary glucose, medication. Very important because there are some medication that causes the delirium, infection, urinary retention, constipation, pain, and also ask about if the patient is taking alcohol or if it is the withdrawal. Clinical assessment, history, function, collateral. So ask and document. Whatever you're asking, not only you have to ask, you have to document. Change from baseline and time course. This is very important. The activity of daily living or instrumental activity of daily living, finance, medication, cooking, shopping, very important because this will help you to differentiate between the mild and moderate. Whether it is mild or moderate, this is very important. That's why I made it red and I made it bold. Driving, falls, wandering, stove, safety, mood, psychosis, sleep, and caregiver burden. Medication, very, very important part that you cannot miss out on any psychology cases, anticholinergic medication, benzodiazepine, opioids, especially when you're dealing with a delirium, with confusion, with dementia, always ask these medication. Vision and hearing. Usually, vision and hearing is the most important part of the treatment when it comes to delirium, because if the patient cannot see properly or hear properly, it is worsening the condition. If there is nobody taking care of the patient, if the patient is left unsupervised, it is worsening the attack or the condition. So what you need to do if you're dealing with a patient that who might have delirium or suspected to have delirium, or the patient has delirium already diagnosed, then you need to provide somebody to be like a person that who is very familiar with the patient, who can talk to the patient, who knows the patient, how to deal with the patient. Being around the patient helps the patient to calm down, and also the patient know how to take care. The somebody that who knows how to take care of the patient should be close to the patient. It is better for the safety of the patient. Another thing is to provide a proper vision, like light, and also the noise. There shouldn't be too much noise, but the patient should be able hearing, because if the patient cannot hear it, the patient will get frustrated and it only can worsen the condition. Then for the memory issue, we have Montreal cognitive assessment, and also we have mini mental status examination. In the exam, they might ask you, and also these two, vision and hearing aids, this might be in the exam, or they love to test you on this one. And also a few things when it comes to the delirium that you need to know, or maybe you should take a note. I should have mentioned it here. Where does it develop a lot? So in delirium, usually it develops in someone that who lives in nursing home. Like 60% of the time, delirium starts in someone who lives in nursing home. So nursing home in terms of location is number one, 60% of the time. And 40% of the time, let's say 30% of the time, because you need to have like 10 more. So 30% of the time, which is the second most common place, is the hospital itself. If the patient is in the hospital, the staying in the hospital can cause delirium. And also the 10% could be medication, could be other triggers and risk factors. Now, another question that you might get is that if there is a question that which one of these assessment for the memory is more sensitive when it comes to dementia or mild and major neurocognitive disorder. Montreal is more sensitive than mini mental status exam. Okay, so remember the MOCA is more sensitive than mini mental status exam when it comes to dementia if you're dealing with someone with dementia, and especially if it is early changes. Collateral history is essential because insight may be limited. So, like we need the most reliable history from the witness and seizure. Also, for delirium, we need collateral history taking or somebody that who is observing or supervising the patient while the patient is having delirium. So that is very important. Or whoever is living with the patient provide you the history, or the nurse that who is taking care of the patient provides you the history. It is very important. So MOCA versus mini mental status exam. So both remember that this is more sensitive, better choice than the mini mental status exam. Just to make it very simple, is generally more sensitive than mini mental status for early cognitive change. But we need to remember that none of these tests alone diagnose dementia. So this one by itself or this one by itself cannot diagnose it, but they're supportive test that helps you with the diagnosis. Rule out treatable causes before labeling degenerative. So, what are the causes or conditions that they can be counted as a cause of dementia that we can just have a solution for it, or we can treat them, we can take care of it, and the dementia is going to be gone, or at least better. So, medication, as I mentioned before, when it comes to psychology and when it comes to neurology, and when you're taking history from anyone, we have a section of uh, asking about the current medication the patient is taking, right? So, especially when you're dealing with a dementia, you need to ask specifically if the patient is taking any sort of medication. If you're doing a NAC-OSCE, obviously you're asking about the medication, but based on that specific station, ask the right medication. So, are you currently taking any medication? Yes. So, you still get points for it, but not 5 out of 5. You will get 2 out of 5. But if you follow it up with, how about medication for sleeping? So it is indirectly verbalizing it or mentioning to the examiner, I'm talking about benzos, right? So now the patient knows, yes, he's talking about sedative and benzodiazepine that causes or makes worse the dementia. So yeah, he did ask it, and instead of giving you 2 out of 5, he's going to give you 5 out of 5. So it means based on the station or based on the case, you need to be a little bit more specific that what type of medication do you think might cause the condition that you need to specify it. So are you currently taking any medication? The patient might say no, or the patient say, yeah, probably a few. Is it sedative? Or we don't have to lead the patient, but if you know the patient is not giving it to you, you need to at least know the examiner that I know what kind of medication I'm talking about. Okay. So, mood, depression related cognitive impairment. Remember that depression is also causing memory issue. How to differentiate the dementia which is caused by depression, and how we can differentiate the dementia that is a major neurocognitive disorder, which is due to degeneration or Alzheimer, right? So, for depression, the memory issue happens later. Let's say you develop depressed mood, you develop anhedonia, loss of interest, you develop hopelessness, you develop feeling guilty, you develop um, fat, um, what else? Insomnia, right? So dig fast that mnemonic. Sorry, not dig fast. MIECG pass, MIECG pass. So you develop all this. Then you develop the memory. So memory issue comes later in the later stage of dementia, sorry, depression. But Memory problem with a major neurocognitive disorder comes early. I hope it makes sense. But the depression comes later. So for depression, the memory comes later. For Alzheimer, depression comes later. Memory comes first. I hope it makes sense. So that's why we call it pseudo dementia. Like if a patient who has depression for 2 years, 3 years, 4 years, and then the patient also have problem with the memory, it's not dementia, it's called pseudo dementia. When you treat the depression, the dementia will be gone. Now, the Alzheimer has, or major neurocognitive disorder has dementia. It is not called pseudo dementia because it starts with dementia. It starts with memory problem. But later on, the patient develop depression. So metabolic, check for the thyroid, calcium, glucose, renal function, and uh, kidney function because they can affect the memory. Nutritional, obviously, for we're living in a country that most of the people who, not most, but probably let's say a lot of people, they are vegan, they're not using meat, so less vitamin B12 deficiency. Less vitamin B12 deficiency and folate deficiency, they both can affect memory and cause dementia. So need to rule out this. Structure abnormality, subdural hematoma, tumor, normal pressure, hypertension, and vascular disease. Substance and toxic alcohol related issue, and Wernicke, heavy metal. So basic workup: CBC, electrolytes, glucose, calcium, creatinine, liver enzyme, TSH, B12, folate, depression screening, medication review, CT, MRI when indicated. So we don't do CT and MRI for everybody when it is indicated. Red flags for the imaging: focal signs, trauma, anticoagulation, rapid decline, rise intracranial pressure, gait first triad, cancer history. Now let's talk about Alzheimer. Alzheimer typical amnestic course. So first of all, the onset is insidious. Insidious, what does it mean? Insidious, it means it starts very subtle and very slow. Very subtle, very slow, and very quiet. And it keeps on progressing. So this is specific for Alzheimer, right? Insidious start or insidious onset and gradual progression. Early difficulty learning new information. So it means the patient has anterograde memory loss. It means when the patient develops the problem will be the anterograde memory loss. The patient has hard time memorizing things, cannot remember things. Like on daily basis, we might lose some of the information, but we keep on refreshing or reminding ourselves of that, right? Or for example, these topics, we have already read it, right? We have everybody knew about this, but now we are refreshing, we are learning, right? We are learning new stuff, and it is supporting the retrograde because retrograde memory is things that we learned before, right? And retrograde new stuff, new stuff. So on daily basis, we might, for example, do you know this guy? I know him, but I can't remember his name. The next day you see him, you just learn, yes, the face is being refreshed, the name is being refreshed, and you know who is this person, right? So you're learning. But the problem with Alzheimer is that he does not get refreshed. He does not get new memories digested or absorbed. So he cannot memorize new stuff. The start is very slow and very quiet and very subtle. And then it starts gradually to get worse. And new stuff, he cannot memorize it. He has difficulty learning new information. So early anterograde memory loss. The reason I insist on this might be asked in the exam. What kind of memory issue the patient with Alzheimer will have at early stage? It will be anterograde memory loss. Repetition, misplaced items, it could happen, misplaced could happen at normal age as well. Mild executive dysfunction. Now, these are early. Now, for the moderate, remember these are early, and out of all of them, the anterograde memory loss is very commonly asked in the licensing exam. So I'm not saying don't remember the rest, but this is very commonly tested. So remember this. So in moderate, now the patient will stop learning a few stuff, right? Stop functionally losing stuff, the functionality. Okay, aphasia, problem with the language. If Alzheimer gets moderate, which will, we cannot stop it, it only gets worse. So the patient will develop aphasia. The patient will have problem with the language, speaking, understanding, naming, reading, writing. Then the patient will develop also apraxia. Apraxia is inability to perform a learned motor task despite normal exam. For example, cannot show how to brush teeth. The patient, the motor skill is normal, the power is there, but he cannot show you how to, for example, brush his teeth or her teeth. Agnosia, inability to recognize object or face, sound or sensation despite intact basic sensation. He can see, but he cannot recognize. So the ability is there, but he cannot recognize it, neither the face nor the object. And visual spatial impairment, visual difficulty understanding the space and visual relationship, getting lost in a familiar place, because you know this place, everything you see every day, right? Like the store, the tree, for example, there is a garbage can, there is, for example, a blue house. These are all the visual memory that we have, right? We know that, oh, I see this. Sometimes unconsciously, we don't even know, but once you see this specific color of this house, you will turn, okay, this is my block. So they will lose this ability. Worsening judgment, poor decision making, reduced insight, unsafe choice, or difficulty planning consequences. Now, late. Please remember these one because they might definitely ask you this. So for the early basic stuff plus new memory loss. Middle, which is the moderate one, you lose everything, almost everything starts with A. We have 4A and 1D. So aphasia, apraxia, agnosia, and also disturbance into visual memory as well. Now, late, you will develop gait disturbance. You will develop dysphagia. You will develop incontinence. You will develop myoclonus and seizure. So this is the late. And in the later stage, also, you will develop depression as well. Okay. But out of all of them, these are very important. Gait disturbance, or you can put D disturbance with walking, or disability to walk, or dysphagia, uh, incontinence, myoclonus. I'm trying to make a mnemonic right now, but I'm not going to waste your time. But anyway, so retrograde versus anterograde. So retrograde is, let's say, if this is you, before the event, memory is going to be lost. For retro, remember retro, the way I remember it, remote. Remote is far away, right? Retrograde, far away memories, like in the past. Anterograde, anything anterior that's coming in front of you. So new stuff that's coming, right? Anterior. So this is how I remember. Retrograde, remote. Anterograde, anterior. New stuff. New stuff. Like this is anterior, right? Anterior, this is remote, past. Yeah, this is the four A's and D. Anterograde, amnesia, aphasia, apraxia, agnosia, disturbed executive function. So in Alzheimer, you have these 4A and 1D. 4A and 1D. What is the first A? The first A is anterograde amnesia. Difficulty forming new memories, earliest classic clue. It's very early classic clue of Alzheimer. Please remember it, you might be asked. Aphasia, language impaired or impairment and word finding difficulty. Apraxia, impaired learning motor task despite intact strain. Agnosia, difficulty recognizing object, pupil despite intact senses. Disturbed executive function, impaired planning, judgment, reasoning, and problem solving. So typical Alzheimer starts with the anterograde Alzheimer. See, again, I insist on this because it is very commonly tested. Then expands to language, visual spatial, and executive domain. For the exam shortcut, gradual memory, first decline in older adult is Alzheimer, until proven otherwise. If you have an elderly who is gradually losing and progressively losing a memory, it is Alzheimer until proven otherwise. So in terms of pathology, unfortunately, you need to memorize this. It's a little bit hard, but it will definitely be in the exam. I'm not saying definitely, but they love to test this and ask you that what is the classic finding in terms of pathology in Alzheimer? Amyloid, beta plaques, neurofibrillary, tau tangle. I have seen these two very common. Hippocampal atrophy, I have seen it. Diffuse cortical atrophy, synaptic loss, and this one. Cholinergic deficit explains why cholinesterase inhibitor may help the symptom. Alzheimer's disease risk factor and genetics. All right, so Alzheimer, the risk factor, I'm just going to point out a few important points. And if you notice, some of them are red and they're bigger. In terms of size, they're bigger than the rest. It means if you see red, it's going to be in the exam. If you see it bigger, it's going to be in the exam, or at least very commonly tested. Okay. So age, strongest risk factor. This might be a question. They might give you a scenario. Like let's say 75, not 75, let's say 65 or 69 years old patient who slowly, for example, develop memory issue and maybe I put a 72. Yeah, 72-year-old male who, for example, who has problem with memory. He cannot remember stuff, or recently he cannot manage his finance, and he gets lost in a familiar place. He got lost twice while he was going back from shopping mall to his place. So see, now you know the patient is having Alzheimer. And then the question at the end is, what is the most or strongest risk factor for this patient condition? The most and the strongest risk factor for this patient is the age. Okay? Age is the strongest risk factor. So this is how they're going to ask you the question. Then in terms of genetic, remember these are risk factor, but they are not diagnostic. Remember the ApoE and ApoE2 and 4, this is protective, this is risk factor. So if they're asking you the ApoE4 increased risk, but does not confirm the Alzheimer, but it could be a risk factor. If they're asking you about the genetic, which I doubt that they asked you, but if they ask you, remember the ApoE E4, which is very commonly involved as a risk factor, genetic risk factor of the Alzheimer. But normally, they love to ask the age as the strongest risk factor. And Down syndrome, if somebody that who has Down syndrome, they will develop Alzheimer, which Alzheimer is usually after 60, right? So it is uncommon in somebody that who is 40 or let's say 38 or 45. But in someone who has Down syndrome, they usually tend to develop early stage or early age. And the reason for that is a gene which is called APP. So remember the APP, this might be in the exam as well. They might give you a scenario about Down syndrome patient that who develop Alzheimer, the patient is getting lost, the patient cannot remember what he was doing here, or he's getting lost in the familiar place. He cannot drive. He doesn't know how to, he forgets faces, and yeah, he cannot cook. Now, the patient has Down syndrome, and patient is younger relatively, for example, 40 years of age. And the question is, what is the most strongest risk factor for this patient? So for this patient, younger age, Down syndrome, the risk factor is the APP gene. So Down syndrome predisposed to early Alzheimer disease through the chromosome 21 APP gene dose. Okay? Also increase the risk, family history, traumatic brain injury, low education, smoking, hypertension, hypercholesteremia, and diabetes. Out of all of them, very commonly used in the scenario would be the family history and will be the hypercholesteremia, hypertension, and diabetes. And then the low education and smoking. Alzheimer treatment set realistic expectation. So now the treatment, I don't know why, but they love to use the treatment in the exam. Okay. Now we need to know which medication is used at which time. This is important. So if you notice, donepezil is red, so it means they love to test you on this one, and memantine. So donepezil, rivastigmine, galantamine, they reduce or slow down the decline of the memory. So the memory is declining whether you like it or not. But these medication is decreasing the speed. So if it is speeding at 100, these medication probably drop the speed from 100 to, let's say, 20. But the speed is still, the decline is still there, right? The patient is still losing the memory, but the speed is not going to be that fast. This is something that you need to remember, that donepezil, rivastigmine, and galantamine are not cure for Alzheimer. They're slowing this memory decline. They slow the memory decline. They do not cure. So this is very important. Please remember it. And they might ask you what is the best first option. Let's say you have a patient who is 7 years old, the patient has Alzheimer, and the question is, what is the first best or initial medication for this patient? Donepezil. So the first best initial medication is always donepezil. Now, if they give you another scenario, they give you another scenario that the patient has Alzheimer, and you start donepezil, and the patient wife is asking you about the medication impact on the patient memory. Which one of the following is the best choice? One of them is it is completely curing the patient, it has no effect, it slowed the decline of memory loss, none of the above. So basically, it slows down, right? Now, another case, you have an Alzheimer patient. The Alzheimer patient has been treated for, let's say, 5 or 10 years for the Alzheimer. Usually, they don't make it that far. Usually, whoever develops Alzheimer, usually they die within the 10 to 15 years of Alzheimer due to infection and pneumonia and this and that. But anyway, let's say the patient had Alzheimer and she has been receiving medication or donepezil for 3 years or 4 years. Now, many mental status exam recently shows that it is 15. So when the mini mental status is less than 17, memantine is the best choice. Okay? Memantine is the best choice. So pay attention to the mini mental status exam. I think I have shared the, I think it was here, no? Yeah, here. So the total score is 30, right? So if the patient in mini mental status is getting less than 17, And if it is asking you what is the best medication for this patient, it actually really directly related to the number of the mini mental status exam. Less than 17, memantine. Okay. Exam phrase: cholinesterase inhibitors may slow cognitive decline and reduce morbidity, but they do not reverse the plaques or restore the independence. So they just slow down. Okay. Beyond medication, treat the mood, optimize sleep, sensory aid, vision, hearing, right? Caregiver education, cognitive stimulation, safety planning, directive, and giving assessment. Behavior and psychological symptoms of dementia. Identify the triggers, treat the pain, constipation, infection, improve sleep, reduce overstimulation, use redirection and routine hearing aids and glasses. Very important to help with their sensory. Caregiver education, consider SSRI for depression and anxiety. So, again, depression will develop memory or pseudo dementia or dementia at the later stage or very severe form of it. Alzheimer will develop depression at the later stage, exactly the same way. But the dementia and depression is not a real dementia, it is pseudo dementia. When you treat the depression, the dementia will go away. But remember, the SSRI is the best choice for Alzheimer with depression. Alzheimer with depression, if they're giving you, let's say they give you a patient that who has been suffering from Alzheimer for five years, and now the patient has also depression. And the question is, which one of the following is the best choice for this patient? You have amitriptyline, you have bupropion, you have SSRI fluoxetine, and you have, let's say, clonazepam. So which one is the best one? Fluoxetine. Why? Because it's SSRI. Okay. Antipsychotic reserved for the severe psychosis, aggression, safety risk, use low dose, short duration, and reassess. Dementia with Lewy bodies, very commonly tested. Again, these are conditions that for some reason they love to test when it comes to dementia. And they're very close to dementia and very close to Parkinsonism. When it comes, it confuses you. Am I dealing with Alzheimer? Am I dealing with the Parkinsonism? Because it has both in one picture. And just to make it very easy for you guys, remember that dementia with Lewy bodies, the patient will have dementia or memory problem will be either 1 year before Parkinsonism or it will start with Parkinsonism. You know, the Parkinsonism is a trap, right? The patient has tremor, the patient has akinesia, the patient has postural issue, and the patient has resting tremor, right? So the patient has characteristic picture of Parkinsonism, but the memory problem happens either 1 year before Parkinsonism or it will start during Parkinsonism, with Parkinsonism at the same time. Not only that, there is dementia, there's Parkinsonism, there's visual hallucination. So you have dementia, you have Parkinsonism, on top of that, you have visual hallucination. So dementia with Lewy body is a combo of dementia, psychosis, and Parkinsonism. Another thing about dementia with Lewy body is fluctuation. Fluctuation, it means the patient is 1 day good, next day bad. 1 day good, next day bad. Today he knows everybody, the next day he doesn't know anyone. For example, he doesn't know his wife, his kids, no one. The next day he knows everybody. So fluctuating of the condition. Good and bad periods in the same day. For example, today I know you in the morning, but I don't know you afternoon. So it's fluctuating, getting better and worse. Another thing is the dream sleep behavior, acting out in dream. So, dream sleep behavior, they might mention this as an act out dream. Antipsychotic sensitive or neuroleptic cautious. So, these are like, I cannot insist enough on this part that you need to know about Lewy bodies, that Lewy body is a combo of dementia, visual hallucination, Parkinsonism, REM sleep disorder, and one of the characteristic finding, another finding is that it is very sensitive to antipsychotic. So the patient has visual hallucination, right? You need to use some sort of antipsychotic, and he is very sensitive to it. And that makes it very easy to diagnose. Okay? So visual hallucination plus Parkinsonism plus dementia plus fluctuation of the condition and REM sleep behavior and sensitivity to antipsychotic. If you have it, this is the Lewy body. Okay? So visual hallucination plus Parkinsonism, fluctuation cognition plus REM sleep behavior disorder, Lewy body. The exam MCQ one exam pitfall hallucination and fluctuation may be mistaken for delirium. So if you see delirium has these two characteristics, visual hallucination and fluctuation. But the patient does not have the Parkinsonism symptoms, right? So you need to ask the next step about the Parkinsonism. The second thing, the REM sleep behavior disorder. Does the patient have Parkinsonism sign and symptom, resting tremor, rigidity? The patient has cogwheel rigidity. The patient has bradykinesia. The patient has balance issue. If the patient has all those, then it is not delirium. It is dementia with Lewy bodies. Okay? And also act out during sleep. Now, dementia with Lewy bodies. For visual hallucination, for Parkinsonism, for fluctuation, dream sleep, and also antipsychotic, I made case for all of them. For example, a 74-year-old man repeatedly reports seeing well-formed children and small animal in the room despite no one else is being there, along with a progressive cognitive decline. So the patient has progressive cognitive decline, dementia, and the patient has hallucination. Parkinsonism. Now, the Parkinsonism, what are the characteristic finding of Parkinsonism? For a 74-year-old woman develops slowness, rigidity, reduced arm swing, and shuffling gait together with a declined cognition. And fluctuation, day to day, an hour to hour variation. So from this day to next day, from hour to hour, the patient is getting better and worse. The REM sleep is 72 hours, 72 years old man punches, kicks, shouts, and act out vivid dream. So this is act out dreams. Okay, act out dream, punching, kicking, shouting, all that stuff. During sleep, sometimes injuring his bed partner years before clear dementia is recognized. So antipsychotic, after a small dose of haloperidol for agitation or visual hallucination, the patient becomes markedly more rigid, sedated, and confused. So the patient is very sensitive to antipsychotic. So visual hallucination, we know this, we know this, we did this, and also this is 1 year rule. Please remember this, how to differentiate this condition from other condition. Dementia before or within 1 year of the Parkinsonism. So dementia either happens 1 year before Parkinsonism or within 1 year of Parkinsonism. How I can make a sentence for this or a scenario? For example, 72 years old male who had gradual memory decline in the last 8 months now developed rigidity. The patient lost arm swing, and the patient has freezing, and the patient has slowness in the movement, and also the patient uh, has problem with the balance, and the patient has resting tremor, right? So it months before the patient noticed that the patient starts having the dementia. So 8 months before, now Parkinsonism, and also this patient is seeing things that other people does not see. Sometimes the patient is good, sometimes the patient is bad. Sometimes the patient recognizes the family member, sometimes the patient does not recognize the family member. What is the best diagnosis? So 8 months before dementia, then the patient developed 8 months later Parkinsonism. Now the patient has visual hallucination. So what is the best diagnosis? Dementia with Lewy bodies. Frontotemporal. Okay, this is very interesting. I have seen this like maybe in every subscription, very commonly tested. This is also dementia, but remember, the frontotemporal is the personality area, right? So the personality change before the dementia happens. So it means the patient has dementia, but first the dementia did not start. The behavior of the patient starts to change. Behavior change, personality change at the beginning, then dementia. So if the personality change, the behavior change starts first, then dementia happen, it is called frontotemporal dementia. Frontotemporal neurocognitive disorder or dementia. So behavior change, for example, disinhibition, the patient becomes apathy, loss of empathy, impulsive spending, compulsive routines, poor judgment. Non-fluent aphasia, effortful speech, grammatical error, speech production difficulty, semantic dementia, loss of word meaning, name difficulty, and fluent speech early. So patient develops all this before developing dementia. Early personality or language change. See, early personality and language change with relative spared memory. So memory is still intact, but the patient starts to develop personality change, language change, behavior change. Then memory problem appears. Often earlier onset than typical Alzheimer. Family history may be present. MRI CT scan may show frontal temporal atrophy. So if you are suspecting to this, if they give you a scenario about someone like this, then they will ask you what will be the next step, which is going to be the CT and MRI of the frontotemporal lobe, because these two will be atrophic, will be small, shrinked, okay, or shrunk, sorry. Frontotemporal neurocognitive disorder, example case, a 58, and usually it is relatively younger than Alzheimer, relatively younger, because Alzheimer usually happen after age of 65 and above. This one usually happens less than 65, 53, 55, 49, 48, relatively young, not very young. Okay, variant, a 58-year-old accountant becomes socially inappropriate, makes impulsive purchases, buys everything, right? Shows apathy and loss of empathy and develops repetitive routines. While early memory is relatively present, so it's behavior variant frontotemporal neurocognitive cognitive disorder. Non-fluent aphasia, if the patient starts with this, with the language problem, or maybe it will start with both of them. The patient will have socially inappropriate. For example, the patient was very nice guy. For example, the patient is a teacher, a professor, and suddenly the patient starts touching people, sexually assaulting people. So this is a personality change. For a professor who used to teach in a university, start touching people inappropriately is not his personality. So it means the personality is changed. On top of that, the patient has difficulty with the language. What kind of difficulty with language does he have? A 63-year-old woman develops slow, effortful speech with a grammatical error. So when he speaks fluently, but the problem is that the grammar is not good. For example, if I am talking to you right now, if I say the same sentence in a wrong grammar, I would say, if I talk to you now, right? So grammatically, the sentence will be awkward, right? So, and difficult getting words out. Sometimes he has problem. He knows the word, but he cannot take it out. But her words meaning is relatively preserved early on. Now, semantic dementia, a 61-year-old man speaks fluently, but progressively loses word meaning, cannot name familiar object, and ask what common word mean. So semantic dementia. Now, the patient developed either one part of this before memory or a combination of these three variants, and then memory problem happens. Early personality or language change with a relatively spared memory. Think of frontotemporal dementia or frontotemporal neurocognitive disorder. Often early onset than typical Alzheimer. Family history may be present. MRI CT scan shows the frontotemporal lobe is shrunk. Vascular cognitive impairment. Vascular is very easy. The reason I say it is easy, if they want to test you, they will mention the patient with a vascular issue, then developed cognition problem. For example, hypertension, usually you will have this hypertension, diabetes, arterial fibrillation, and most likely they mention a stroke, just to make it very simple for you. So it means if you have a patient who has a vascular issue and develops dementia, it is a vascular dementia. Let's say hypertensive patient with dementia, what is the problem? Hypertension. What did the hypertension did? Damage the vascular, or the vascular was affected, which caused hypertension. Now I could say the vascular is the cause of the dementia. Or a stroke, the patient had a stroke, now dementia. So vascular dementia, arterial fibrillation, or diabetes, which we know that diabetes affects everything. So you can blame it for everything. So feature bradyphrenia, slow thinking, and slow learning. This executive syndrome. What is this executive syndrome? Same thing, like you can't do daily activity. Slow gait, uh, white matter disease, small vessels burden, pattern is abrupt. Another thing about vascular dementia is stepwise and progressive. So the patient is getting worse, so one step down, and he stays there. He stays there like that and then worsen. And then he stays there and worsen. Stays there and then worsen. So it's like a step. He doesn't get like, he doesn't go all the way down. So he stays there in each level for a bit and then drops and get worse and worse, like stepwise. So cognitive slowing plus executive dysfunction plus slow gait vascular risk factor or vascular neurocognitive disorder or dementia, CT scan, MRI can show infarct, lacunes, white matter disease, and vascular burden. So if you do the CT scan and MRI, these are the findings. Mixed Alzheimer plus vascular disease is common. So for every single one of them, I made an example, but I think you guys got the point, right? Normal pressure hydrocephalus. Normal pressure hydrocephalus has a triad. A triad is the patient will have gait problem, urinary incontinence, and dementia. So if you have somebody who has these three these three triad, dementia, incontinence, and gait problem or ataxia. Dementia, urinary problem, and ataxia, it is normal pressure hydrocephalus. Remember, enlarged verticals with a normal cerebrospinal fluid pressure. The reason they call it normal pressure hydrocephalus is when they check for the CSF, uh, the LP, the cerebrospinal fluid pressure is normal. Okay, so the triad is gait disturbance, ataxia, urinary incontinence, and cognitive decline, which is dementia. Investigation CT MRI. In CT MRI, you will see ventromegaly out of proportion to the atrophy. So this is very important. Please memorize it because they might ask you the clinical finding. Like frontotemporal dementia is frontotemporal atrophy, right? For normal pressure hydrocephalus, it is ventromegaly out of proportion to atrophy. Large volume LP may predict shunt response. The patient will be wet, wobbly, wacky. Rapidly progressive and genetic dementia pattern. These are genetic dementia. So the Cortez-Jacobs disease, rapidly dementia, very progressive. When I say rapidly, please write it down. I forgot. It is very important. Within months, 1 to 2 months, the patient is going to go completely demented. It is that progressive and rapid. Okay? Within a month. For example, for Alzheimer, it takes months to years, right? In most cases, years. But with Curtis Jacobs, it is super rapid. Within 1 to 2 months, the patient is completely demented. But rapidly demented over weeks to months, plus myoclonus and ataxia. These tried. Rapidly demented within weeks to months, plus ataxia plus myoclonus is equal to CJD, Cortez-Jacobs disease. MRI, EEG, CSF testing. Remember this. Huntington. Huntington, instead of myoclonus, put Corey. Corey, psychiatric symptoms, cognitive disorder, family history. So almost the same thing, but not as rapid, but Corey. Okay? Corey, psychiatric symptoms, cognitive decline, family history, genetic testing. Depression related, obviously we know low mood, anhedonia, sleep or appetite change, variable efforts, mood assessment and treatment. So the patient will develop the mnemonic we have MIACG pass to maybe depression, the depressed mood with five or more than five of the others, or anhedonia, which in most cases these two is more than enough, or anhedonia with four or more than four of the others. So if the patient has that and then memory problem, it is pseudo dementia. Treat the depression and memory issue will go away. Rapid dementia plus myoclonus and ataxia, Jacob's disease, Corey, psychiatric symptoms, family history, Huntington disease. Rapidly progressive, okay, for Cortez, a 68-year-old man develops rapidly progressing memory decline over 2 months. Over 2 months, completely demented, become unsteady, ataxia, when walking and has brief shock-like jerks triggered by the sound. This is myoclonus, right? Rapidly progressive demented or dementia, unsteady walking, ataxia, shock-like jerk movement is myoclonus, is equal to Jacob's disease. And this is what we do, Huntington. Usually this is younger than this, okay? A 42-year-old woman has involuntary fidget movement, Corey, right? Depression and irritability, psychological, and worsening with the performance. So in this case, you can also put cognitive issue. Her father had similar illness in midlife. It means father died of Huntington disease. So most likely it is Huntington and do a genetic testing. Depression related, obviously we know this, it's easy, low mood, low interest, poor appetite, poor sleep, variable efforts, and the patient has, thank you. The patient has depression-related cognitive impairment, mood assessment, and treatment. So rapid dementia plus myoclonus, ataxia, think about Jacobs, Corey, psychological symptoms, think about Huntington disease. Always exclude reversible cause and delirium before diagnosing degenerative dementia. Neurocognitive disorder differential. Key clinical clues. So Alzheimer's disease, memory first. Memory first. Episodic memory loss is the earliest and the most prominent feature for forgetting recent conversation and even repeating question and stores. So the patient is gradually declining. If you notice, look at this, gradually declining. Now, Lewy body disease or Lewy body dementia, hallucination and Parkinsonism. Fluctuating cognition with visual hallucination and Parkinsonism feature. Visual hallucination, Parkinsonism, slowness, rigid tumor, fluctuating attendance and alertness, plus dementia, obviously. And now, if you notice, the patient is getting better, worse, better, worse, better, worse, better, worse, better, worse. So it's fluctuating, right? Frontotemporal degeneration or frontotemporal neurocognitive disorder or frontotemporal dementia. Disinhibition in language change or personality change or behavior change. Early change in behavior, personality, or language, memory related, spared early. And then the dementia. And this one is going this way. Vascular cognitive impairment or vascular dementia, a stepwise decline. See, stepwise decline, like stepwise. And executive slowness, cognitive issue related to the cerebrovascular disease, executive dysfunction, prominent stepwise decline, poor planning, organization, slow thinking, history of stroke, or vascular risk factor. Usually they love to use a stroke, and to be honest, it makes it very easy. Stroke, dementia, vascular, right? So normal pressure hydrocephalus is gait incontinence dementia. Gait, ataxia, incontinence, and dementia. And this is we have already talked about this. Now, major neurocognitive disorder management ABCD framework. So A is affective symptoms and activity of daily life. B for behavioral problem, caregiver support, cognitive medication, and cognitive stimulation. D for directives and driving. S for sensory enhancement, glasses and hearing. 8, very important. D for driving. C for care. And B for behavior, and A for affective symptoms. Always address these, which we already talked, right? The driving, safety, falls, wandering, stove, medication, finance, power of attorney, advance directive, care, giver burden, and community support. These are very important part of the MCCQ1 and NACOSKI. For the MCCQ1, they might ask you, for example, which one of the following is supposed to be done before you discharge. Obviously, one of them will be in the option. Or the patient has problem with seeing and he has problem with hearing. So what would be the next step? Obviously, you have to provide him with the glasses and also hearing aid, right? So it will be this way. But in NACOSKI, if you're doing NACOSKI, so this is something that you need to add it as a part of the consultation before you discharge. For example, there is a patient with Alzheimer and the patient needs a consultation about Alzheimer. I mean, he is accompanied by a nurse, so you need to, or by his wife, let's say by his wife. So please do a consultation to his wife about Alzheimer and discharge the patient. So before you discharge, you have to address all this. You cannot allow the patient to leave the clinic without knowing all the safety. Okay. Mild versus, so let's break it down and make some, talk about some exam traps. Mild versus major, function decides, independence versus dependence. Delirium first, acute fluctuating inattention, medical emergency. So don't worry about anything else. You have to admit the patient right away. Depression mimics low mood, variable effort, and mimics dementia. Alzheimer gradually memory first decline. Sudden stepwise suggests another condition or cause, which is called vascular dementia. Lewy body, hallucination, Parkinsonism, antipsychotic sensitivity, and dementia, normal pressure hydrocephalus, gait, issue, incontinence, and ventromegaly. So I had to put this dementia here. Ventromegaly is the CT scan and MRI finding. Clinical scenario, most likely diagnosed. So cognitive decline, preserved day-to-day activity. What is it? Mild. Now, cannot manage medication, finance, stove safety. Now it is major because the patient cannot do daily activity. Acute fluctuation in attention is acute confusion, delirium. Gradual memory, first decline, Alzheimer. Visual hallucination, Parkinsonism, Lewy body with dementia. Disinhibition and language and personality behavior, then dementia, frontotemporal dementia. Slow thinking plus stroke, vascular. Gait, urinary cognitive, urinary incontinence and dementia, normal pressure hydrocephalus. Rapid dementia, within weeks to months, plus myoclonus, plus ataxia, I forgot to put the ataxia, Jacob's disease. Core, psychiatric, family history, Huntington. Macrocytosis and paresthesia, vitamin B12 deficiency, or folate. Final take home, we have already discussed all of them, and these are the Alzheimer treatment. Okay, so for the treatment, I think we did discuss the treatment as well. Mild cognitive impairment without dementia. Do not routinely start cholinesterase if the patient does not have dementia completely. So it is mild. For the mild, we don't start it. Start cholinesterase or amantinin, monitor adults reversible cause lifestyle optimization. Now, mild Alzheimer dementia, first line is if they're asking, which most likely they will ask you this. So what is the most important, what is the first best initial pharmacological treatment for mild Alzheimer? It will be donepezil. If you don't have it, rivastigmine, galantamine. So one of them has to be there, which is cholinesterase inhibitor. For the moderate Alzheimer, continue or start cholinesterase. If it is there, continue. If you haven't started yet, start it. Consider adding memantine. We add memantine if it is moderate. But again, depending on the mini mental status exam, we will decide. Severe Alzheimer dementia, donepezil may continue, memantine appropriate, consider combination therapy if ongoing benefit. So it means if you have Alzheimer, and the Alzheimer is a non-amnestic stage, right? In mild, in mild we have subtype, amnestic, non-amnestic. If it is non-amnestic, so the memory is not the problem, is the language and other stuff. So you don't have to start the medication. But once the memory is started, which is the amnestic stage or amnestic subtype of the mild case, then in that case you start a cholinesterase inhibitor, which is the donepezil and rivastigmine or galantamine. If this doesn't help, you can think about adding memantine and in the severe as well. But if the patient is coming to you and the mini mental status is 15, you start with memantine. You start with memantine, okay? Reassess benefit, tolerability, plus weight, adherence, function, and caregiver goals every 3 to 6 months. So it means that the follow-up for Alzheimer's should be done every 3 to 6 months. You can't just discharge the patient and leave it, let her go or let him go forever. So you ask the patient to come back in 3 months or 6 months. Okay, 3 to 6 months. This might be a question as a post-encounter question in NACOSKI, or it might be a question in MCQ1. After you discharge the patient, when is the best time for the patient to come back for a follow-up or reassessment? The answer will be 2 years, 4 years, never 3 to 6 months. 3 to 6 months will be the right answer. Another thing about the medication choice, donepezil, rivastigmine, if the patient says that they want patch, not the medication, they prefer patch, then go with the rivastigmine, okay? The rest, I think, we have already mentioned. And another thing about the cholinesterase inhibitor side effect is nausea, diarrhea, weight loss, bradycardia, and syncope. If the patient has bradycardia and weight loss, then you don't use that. And instead, you can start with the memantine. Right. These are the short notes, which I'm gonna give you guys the opportunity to go through them. Thank you very much.